Hello, my name is Duncan Stearns. I'm coming to you from snowy and lovely Cleveland, Ohio, and I'll be moderating today's session, Immunology and Immunodeficiency, presented by Dr. Sung-Yun Pai from the National Institutes of Health. A few announcements before we start. Don't forget to network with colleagues in the chat box at the bottom and utilize the Q&A feature to ask the speaker questions during the talk and subsequent to the talk. If you see other questions that you would like to see answered, you can click to vote the question to raise the question on the priority list. Following the lecture, there will be a dedicated live question and answer time at the end of the presentation, lasting probably about 15 minutes. If you experience any issues viewing the session, please try refreshing your screen or visit the support tab at the top of the screen. Now I'll turn the lecture over to Dr. Pai. Thank you.
Hello, everyone, and welcome to the ASPHO Board Review Lecture on Immunology and Immunodeficiency. I am Sung-Yun Pai, formerly of Boston Children's Hospital and now of National Cancer Institute at the National Institutes of Health. All of the talks in this course series is following this topical structure suggested by the American Board of Pediatrics. And for the purposes of this lecture, I will review immunology and immunodeficiency, starting with normal lymphocyte development and function, followed by immunocompromised status in hematology, oncology, and transplant, diagnosis, management, and treatment of infections in the immunocompromised host, and then finish off with primary immunodeficiency states made easy. So starting with normal lymphocyte development and function. So as you know, all of the immune cells are derived from the bone marrow, similarly to red blood cells and platelets. These cells can be divided into those of the innate immune system and those of the adaptive immune system. The cells of the innate immune system are comprised of the neutrophils, macrophages, dendritic cells, and natural killer cells. The neutrophils and macrophages have also been covered in another lecture. And once you go through each of these cell types and understand what their functions are, then it becomes very apparent what are the types of infectious organisms that the person is predisposed to if there's something wrong in terms of these cells' number or their function. So starting with neutrophils, we know that these are very important for phagocytosis and for producing bactericidal reactive oxygen species. Macrophages are primarily phagocytic cells that also perform roles in antigen presentation and in clearance of debris such as apoptotic or necrotic cells. Dendritic cells are so-called professional antigen presenting cells and also perform phagocytic functions. Then we get into different types of lymphocytes, as shown here, divided by the types of cell surface markers they express. Natural killer cells express both CD16 and CD56, and these are cells that kill virally infected cells and also kill tumor or foreign cells. The other three lymphocyte subsets depicted here are part of the adaptive immune system. Amongst those, T cells are particularly interesting in that they do not complete their maturation in the bone marrow, but must instead mature through the organ called the thymus. These T cells can be divided into those that express both CD3 and CD4, and those that express CD3 and CD8. These are both part of the cellular immune system. CD4 T cells, as we will discuss further, help B cells to class switch and help CD8 T cells to kill, whereas CD8 T cells are cytolytic T cells. Finally, B cells express CD19 as well as CD20, and these are cells that make antibody, which in turn opsonize bacteria. B cells are also important antigen-presenting cells. So again, once you have understood what the individual functions of each of these immune cells are, then it becomes quite easy to determine which types of infectious organisms are critically dependent on the function of these cells. So in the case of neutrophils, this means bacteria and fungi. The actions of macrophages and dendritic cells contribute to all types of immune function. Natural killer cells are most important for fighting DNA viruses. CD4 and CD8 T cells are important for all the opportunistic infections, such as pneumocystis, fungi, as well as viruses. And finally, if there's a problem with B cell number or function, then this predisposes people to bacterial infection, particularly encapsulated organisms. We're going to review now the major arms of the adaptive immune system, and the majority of this talk is going to be about the adaptive immune system, since some of the innate immune cells are covered in other lectures. As you know, these are divided into this cellular immune arm and the humoral immune arm. The cellular immune arm means the T cells, and you know that 90% of these are so-called alpha beta T cells. These are T cells that express a T cell alpha, TCR alpha, and TCR beta protein complex to form the T cell receptor, which in turn is complexed with the signaling module, the CD3 complex. These are then divided into CD4 positive T cells and CD8 positive T cells. The CD4 positive T cells recognize antigen that is complex to MHC class II on antigen presenting cells, and they perform helper functions. What this means is that CD4 T cells cooperate with B cells to induce class switching. They control opportunistic infection, and they perform cancer surveillance. There's also an important subset of CD4 T cells that perform regulatory functions. These are CD4 T cells that also express constitutively CD25 and express the transcription factor FOXP3. CD8 T cells, on the other hand, have T cell receptors that recognize antigens that are complexed instead of to MHC class II to MHC class I, expressed on antigen presenting cells. These perform cytolytic functions and kill virally infected cells, as well as control opportunistic infection. And again, CD8 T cells are also critically important for cancer surveillance. The humoral immune arm, on the other hand, is composed of the B cells, which produce antibody. B cells produce IgM and IgD first, and only produce IgG, A, or E after isotype immunoglobulin class switching. In addition, B cells undergo additional mutations in the Ig locus, in other words, the locus that encodes immunoglobulin and the surface B cell receptor. And B cells carrying receptors with higher affinity are selected in a process called affinity maturation. These B cells then produce antibodies that opsonize bacteria, and these are especially important for respiratory pathogens, skin flora, and encapsulated organisms. So now we're going to review how it is that the adaptive immune cells develop, and then further into how they adapt and function. So starting with HSC in the bone marrow, from which all of the blood cells are derived, B cells primarily complete their maturation within the bone marrow. They undergo a serial set of developmental steps that involve rearrangement of the immunoglobulin heavy and immunoglobulin light chains. As you know, CD34 is a common marker for hematopoietic stem cells and other progenitors. And then those that express CD19 and CD10 are pro-B cells. And it is at the pro-B cell stage that the first step of rearranging the B cell receptor, in other words, the immunoglobulin locus, starts to occur, and the heavy chain, or IgH, is rearranged. You don't really want to bother having those cells go to the next step of B cell receptor rearrangement unless that heavy chain functions. And therefore, the IgH molecule is paired together with a so-called surrogate light chain, sort of like a pretend light chain. And it's only after that unit signals that the pre-B cell will start to undergo light chain rearrangement. Then once that light chain and heavy chain are complexed together, it is expressed as IgM on the surface of the immature B cell, which has lost CD34 expression and has gained CD20 expression in addition to CD10. Those cells then further mature in the spleen and express IgD, And then these are circulating as naive B cells in the blood. The T cell receptor side has a parallel process in which HSC leave the bone marrow, circulate, and then seed the thymus. And then is within the thymus that the T cell receptor rearrangement occurs. And again, this occurs in steps. So first, the TCR beta locus is rearranged at the pre-T cell stage. In other words, in double negative thymocytes that don't express either CD4 or CD8. And then after this pre-T cell receptor, which is the TCR beta complex to a pre-TCR alpha, or sort of a pretend TCR alpha protein, that then the cell undergoes the further step of rearranging the TCR alpha locus. Those are the cells that are then double positive, CD4 positive and CD8 positive in the thymus, and express both the TCR alpha and the TCR beta. And then that T cell receptor triggers the double positive thymocytes to proliferate and then differentiate into either single positive CD4 thymocytes or single positive CD8 thymocytes. And then those cells are exported into the periphery. Now, keep in mind that every single T cell and every single B cell expresses a unique T cell receptor or B cell receptor. This is as a consequence of VDJ rearrangement, the process where variable genes, diversity genes, and joining genes are mixed and matched within each cell. And this then leads to a combinatorial process where you can have millions of different antigen specificities. And it is this property of having multiple polyclonal types of receptors, and then the process of how those receptors interact with their cognate antigen, that leads to adaptation of the immune system and the generation of memory. So to go through this step by step, when a CD4 T cell or a CD8 T cell encounters an APC that bears within the cleft of its MHC, either class 2 or class 1, the cognate peptide that the T cell receptor is specific for, this will trigger clonal proliferation of that particular T cell. And then most of these cells will go and perform their effector function and then die. And those that are remaining after this clonal expansion and performing the effector function will differentiate into memory T cells. In the case of B cells, a similar process occurs in which the B cell bearing its surface receptor of IgM will recognize the cognate antigen, the antigen that that particular B cell is specific for. And this, in combination with T cell help, will lead to immunoglobulin class switching and this process of affinity maturation within the secondary lymphoid organs, the spleen and the lymph node. This will then lead to several different outcomes. There will be some B cells that become memory B cells, and those will, in combination with the memory T cells, be prepared in case that antigen is encountered again to yield a better, stronger, faster memory response, a so-called anamnestic response, where the clonal proliferation and the function of those cells will be faster because those memory cells are primed to respond. Another portion of the B cells will mature into plasma cells. These will be inhabiting tissues in the gut, in the bone marrow itself, and these will be cells that can produce specific antibody IgG, A, and M in a long-term, long-lived fashion. This is a point where I usually have a little interlude about the spleen because it's required that I give you some background on what the spleen does, but it doesn't really fit into any particular location. So there are several immunological functions of the spleen. It is the site of filtration and innate immunity. It's important for opsonization of encapsulated organisms because organisms that encounter the spleen opsonized by antibody will have Fc receptor sticking out of the complex that can then be recognized and cause that opsonized organism to be consumed by macrophages. The spleen is an important site of primary and secondary adaptive immune responses. It is the site where T cells can get primed by APCs and then interact with B cells, which make specific IgM, and those B cells will then mature, class switch, and undergo affinity maturation. And then finally, the spleen is the site of a specialized B cell population, marginal zone B cells, that respond to polysaccharide antigens and generally take until 2 years of age to be generated. So now we're going to go through how immunological function is assessed. The first step is just to count them. So enumeration of lymphocytes. This means total lymphocytes and also subsets. So to begin with, I encourage every hematologist who comes out of this course to remember that every time you get a CBC, don't just calculate the absolute neutrophil count, but also take a look at the absolute lymphocyte count. And you will already have some measure of immunological function of the adaptive immune system right there. And then within the absolute lymphocytes, you can divide them further into measuring CD3 positive T cells, CD19 positive B cells. You can use CD16 or 56 or a combination to measure NK cells. And then within T cells, measure the CD4 and CD8 T cell compartments. This is a figure showing you the normal values of lymphocyte subsets in children and adults. And it's pretty obvious here, if you look from neonatal through to adulthood, that the absolute lymphocyte count, the total CD3 counts in the white bars, and the CD4 counts in the striped bars are higher in young children. B cells, which are depicted in the black bars, are maximal at 2 months to 2 years, and then they contract, and many adults will have something on the order of 200 B cells per microliter. Whereas the NK cells in the checkered bars, aside from the neonatal period, are pretty stable over time. Just to drive home this point one more way, if you line up together the ALC and the various subset absolute values, averages, and then minimums and maximums for adults versus an infant 1 week to 2 months old, you can see that the lower limit of normal for an infant, 3,500 per microliter of the ALC, is much higher than the top value for adults at 2,800. What this means is that an ALC of 1,000 to 2,000, which would be perfectly fine in an adult, in an infant is highly abnormal. And so this is something that you should also pay attention to every time you see a CBC. How about measuring immunological function? There are tests of nonspecific and specific function. The nonspecific functional tests for T cells include proliferation to mitogens. These are substances largely derived from plants that lead to non-antigen dependent proliferation. This includes things like PHA, pokeweed mitogen, and CON-A. On the B cell side, you can measure total immunoglobulins, in other words, IgG, A, and M. You can also measure subclasses, although the utility of measuring subclasses in the context of a pediatric hematology oncology practice is pretty limited. You should also remember that because B cells are dependent on T cells for class switching and for their maturation and function, antibody production also requires intact T cell function. Regarding the test of specific function, in the case of T cells, you can measure proliferation to specific antigens, such as tetanus or candida, tetanus being one that is dependent on having been vaccinated, and candida being one that most people have been exposed to in the environment, even small children. You can also perform skin testing, in other words, an intradermal candida control. This is pretty standard if you're going to be doing a skin testing using PPD for tuberculosis. In the case of B cells, you can measure antigen-specific antibody. And it's important to distinguish between those antibodies that are generated against protein antigens. This includes many of the common childhood-killed vaccines, such as tetanus and hepatitis B surface antigen. Whereas there are other antibodies that are carbohydrate antigen specific, and this includes all the blood groups, in other words, anti-A and anti-B in the case of somebody who is blood type O, and responses to the 23-valent Pneumovax, which is a polysaccharide rather than a protein vaccine. And remember again that antibody production, in this case, antigen-specific antibody, also requires intact T cell function. This is what I like to call immunoglobulin for dummies. And there are some board questions that do tend to focus on this concept. So as you know, there are three major types of circulating IgGs, IgM, IgG, and IgA. IgM is pentameric, is low affinity, and because of its pentameric structure, it does not cross placenta. It's only present as about 5 to 10% of circulating immunoglobulin. Most of the circulating immunoglobulin is IgG, which is monomeric, high affinity, and does cross the placenta, whereas IgA is either mono or dimeric, is primarily present at mucosal surfaces, but also circulating, and these are again low affinity and do not cross the placenta. So once you understand this concept, then this makes it very easy to understand what are the norms for these various immunoglobulins and how they change with age. So in the case of IgG, because there's placental transfer, the norms depicted here over different ages, with the top line being the 90th percentile and the bottom line being the 10th percentile, is showing that newborns basically have adult level of immunoglobulin, which makes sense because they are carrying their mother's immunoglobulin in their bloodstream. And then conveniently, there's what I like to think of as a physiologic nadir at 2 to 6 months, which is very similar to the timing of the physiologic nadir when fetal hemoglobin switches over to adult hemoglobin. And so you can see here that at age 3 months, the lower limit of normal for immunoglobulin is quite low, and as is the upper limit, and then this increases over time. In contrast, IgA increases from birth to adulthood because there is no inheritance of IgA from the mom, and the same for IgM. So that finishes the section on normal lymphocyte development and function. And now we will go through relatively quickly these next two sections. What I find over years of teaching this course and having taken the boards myself more than once, including in recertification, is that the questions that are posed in these sections tend to be pretty easy and I think pretty addressable from your regular practice and not something that you have to study too hard for. So we will talk now about immunocompromise in hem/onc and transplant. There are several host factors which cause immunocompromise. This includes loss of physical barriers, medications, acquired and congenital defects in cell number, and acquired or congenital defects in cell function. And we know that the treatments that we give, particularly for treatment of cancer or conditioning in the setting of hematopoietic stem cell transplant, impacts on all of these. So in terms of loss of physical barriers, it is common for chemotherapy to cause mucosal impairment, and many of our patients have central venous lines which breach the skin barrier. Medications, including corticosteroids, specific immunosuppressants, and antibody therapies are immunosuppressant. And then, as you will see further, particularly in the setting of hematopoietic stem cell transplantation, we are inducing severe defects in terms of neutropenia and CD4 lymphopenia. So what happens to a patient after a typical myeloablative transplant? We give them conditioning, we infuse cells on day 0. And then we all know that the rest of the time over the next 3 to 4 weeks is spent inpatient. And because of the suppression of bone marrow function, there is extreme neutropenia, transfusion dependence, and it takes until day 21 to 30 after a typical myeloablative transplant for there to be neutrophil engraftment. Early outpatient from day 30 to day 100, the patient may still need some transfusions. This is a prime period for acute graft versus host disease risk. And then in the late outpatient time after day 100, it takes up until about a year post-transplant for most patients to complete the process of weaning off of immunosuppression and to get past the majority of the chronic graft versus host disease risk period. So putting this into context, you will see that in addition to what we tend to focus on, the absolute neutropenia during the inpatient stay, there is also a profound defect in lymphoid recovery, particularly in CD4 T cells. So if you depict from the time of transplant up through 24 months post-transplant, what is the time period that each of these immune cell types, neutrophils, NK cells, B cells, CD8 T cells, CD4 T cells, and naive CD4 T cells is depressed or below the lower limit of normal? You start out with low everything, and neutrophils and NK cells tend to recover fastest. So at a time when you're checking ALCs in a patient who is 1 or 2 or 3 months post-transplant, a lot of those lymphocytes are going to be NK cells, and then later some B cells. CD8 T cells tend to expand quicker than CD4 T cells and tend to be less dependent on regeneration of new T cells from the thymus. But because it takes 3-6 months or more for HSC to seed the thymus and give rise to naive CD4 and CD8 T cells, and because this process is faster in children than in adults, you can see that the time period where CD4 T cells are out of the range of normal, and especially naive CD4 T cells is out of the range of normal, is many, many months, and in adults up to years. When you overlay on top of this that we are giving medications such as cyclosporin and tacrolimus to prevent graft versus host disease, which are suppressing the function of those T cells that are there, this explains why it takes time for the patients to recover IgG production, because first they have low B cell number, then they have low T cell number, then we're suppressing the function of those T cells, and proper function of those T cells is required for the B cells to produce IgG. Finally, this underlies why we vaccinate patients for after stem cell transplant later, to try to catch them at a time when they're likely to have sufficient immune or constitution to respond. So it's pretty typical not to start revaccinating with protein antigens until 6 months at the earliest, 9 months or 12 months after transplant. And then we don't usually revaccinate for live vaccines until 2 years post-transplant. And we delay also carbohydrate vaccines until 24 months. This goes back to the point that I said earlier about marginal zone-like B cells in the spleen taking until age 2 years during ontogeny to mature, and these being especially important B cells for carbohydrate responses. It turns out that the development of carbohydrate response after transplant pretty much takes about the same amount of time it does during childhood. I'm also going to review for you briefly the post-transplant immunosuppression medications that we tend to use and how they further compromise CD4 T cell function. So as you know, there are some agents that are directed at lysing T cells. This includes alemtuzumab, antithymocyte globulin, and high-dose methylprednisolone. There's a second class of agents, which are inhibitors of T cell activation, TCR activation, and early cytokine production. This includes cyclosporin and tacrolimus, which are both calcineurin inhibitors and interfere with early IL-2 production. Then the third category are inhibitors of clonal expansion and proliferation. This includes agents like methotrexate, mycophenolate mofetil, and sirolimus, which is an mTOR inhibitor. So the idea behind most graft versus host disease prophylaxis medications is to combine agents from these different classes. For example, pairing cyclosporin with methotrexate, or pairing tacrolimus, which would interfere with early IL-2 production, with an inhibitor of IL-2 receptor, in other words, sirolimus. Finally, once you have all of this in your head, it becomes relatively easy to understand what infections are likely to occur given your time post-transplant. So in the early pre-engraftment period, day 0 to day 30, the main immunological defect you're dealing with here is profound neutropenia in the presence of a catheter. And this therefore predisposes people to gram-positive and gram-negative bacteria, to anaerobes from the gut, to Candida and Aspergillus. For reasons that I don't completely understand, HSV reactivation tends to be at this time, and then anytime you could get a respiratory infection. Early post-engraftment, this is a period of time that is most characterized by lymphopenia, especially CD4 T cell lymphopenia, and the fact the patients are on cyclosporin or tacrolimus. They also may have acute graft-versus-host disease, and they often still may have a catheter. So there's still problems with bacterial infection, but this is largely catheter associated. Aspergillus becomes a bigger player at this time. CMV and EBV lymphoproliferative disorder are important at this time, as well as pneumocystis or toxoplasma. And then finally, late after day 100, when most people no longer have a catheter, there's still problems with CD4 T cell lymphopenia and T cell suppressive medications. But additionally, there are some layered risks due to possibly having chronic graft versus host disease, and patients still having poor immunoglobulin production. So this is underlying the problems with encapsulated organisms. There continue to be problems with Aspergillus, CMV, and EBV lymphoproliferative disease. This is also a common time for varicella reactivation, and you continue to have problems and need to prevent pneumocystis and toxoplasma. Moving on to diagnosis, management, and treatment of infections in the immunocompromised host. This again is material that I think most people are pretty aware of. And I find these types of content portions are difficult to test because I think they're unlikely to ask you questions about very specific antibiotics. I also want you to keep in mind that there are times when I'm going to refer to guidances that have been put out very recently, and I'm not sure how those guidances will translate into new questions or how quickly the questions will catch up. So going very quickly, in terms of bacterial infection, I think what you're likely to be tested on the boards is about empiric treatment for fever neutropenia. You know that the organisms that we're targeting here are gram-negative rods and gram-positive cocci. There's some caveats in that some organisms are very prevalent but less severe, such as coag-negative staph or anaerobes, and that you should always consider individual risks and local epidemiological differences. Why are people at risk? Because of severe neutropenia for greater than 7 days, the presence of a catheter, mucosal breakdown. All transplant recipients are at high risk. And then in terms of management, the general principles are that you shoot first and ask questions later, draw blood cultures, start treatment, don't wait for urine or other tests. The literature at this point supports monotherapy for most patients, and the types of agents that are recommended include anti-pseudomonal beta-lactams or fourth-generation cephalosporins or carbapenems. You can consider addition of a second agent depending on special circumstances. Additional thoughts, prophylaxis has been shown to decrease infection and possibly survival in adults, but the recommendation is less clear in children, and it's also less certain what the real balance is in terms of how this might impact on regular flora and also the epidemiology of resistant organisms. You must perform a physical examination, but you will rarely identify a cause. And you should perform a chest x-ray only if there are respiratory symptoms. If you do choose to do double gram-negative rod coverage, you can stop after 48 hours of negative cultures and consider addition of other agents if still febrile, but with instability, not just for persistent fever. And finally, there are very old studies showing that stopping antibiotics after 7 days in persistently neutropenic patients leads to many of those patients developing fever or hypertension. So you should only stop if they're afebrile, have negative cultures, and there's strong evidence of mirror recovery. Moving on to fungal prophylaxis, the agents that we are targeting are yeast and mold. And the types of patients who should receive prophylaxis are those patients who are anticipated to have severe neutropenia for greater than 7 days, especially if they are also on empiric antibiotics, and those who have suppression of T cell function or specific defects in neutrophil function, such as CGD. Therefore, the patients who should get prophylaxis are the patients listed there. And while the typical agent has long been fluconazole, I have listed the reference below for the 2020 guidelines that reflect that there are many more molds that are needing to be prevented than in the past. And therefore, the new recommendation, which may or may not be reflected in board review questions yet, is that echinocandins or a mold-active azole should be considered first line for prophylaxis. Moving on to empiric treatment for fungal infection in the setting of fever neutropenia. Again, we are trying to target the same organisms, and these are the same types of people that we are using empiric coverage for bacterial infection. The patients who should be considered are patients who are undergoing transplant, AML induction, high-risk ALL, relapsed leukemia, who, despite fever and neutropenia coverage for bacteria, are unresponsive and remaining with fever. Due to the poor positive and negative predictive value of the tests listed, such as galactomannan and beta-D-glucan, fungal tests such as these are not recommended for guidance, and the agents that should be used are anakinra or liposomal amphotericin B. Pneumocystis, we know that any patient with CD4 lymphopenia is at risk. This includes high-dose chemotherapy, transplant, solid organ transplant, and primary immunodeficiency. Bactrim is the agent of choice for prophylaxis with the alternatives that are listed, and treatment is high-dose Bactrim. Whether you should use adjunctive corticosteroids, as is the case in HIV, is less certain in our population, and then there are some alternatives to Bactrim listed below. Finally, viral infection, prevention of viral infection in allogeneic transplant recipients. The idea behind instituting some prophylaxis for HSV, CMV, or VZV is the fact that these patients are T-cell lymphopenic and are on graft-versus-host disease prophylaxis and treatment in the setting of poor IgG production. The types of patients that should receive prophylaxis, the agents to use are all listed here for these three viruses. Now I'm going to move on to the last part, which tends to be the part that gives people the most anxiety. But my thought is that if you have gone through this lecture and understood normal lymphocyte development and function and the assessment of lymphocyte numbers and function, then this puts the primary immune deficiency states into context. And so you should keep it in proportion. Remember that only about 10% of the questions are going to be, it might even be 5% are going to be in these categories. So you should proportion your study time and know that you're probably going to get several questions, but it's not going to be many, many questions on this issue. I like to think of primary immunodeficiency states as being able to be captured in a single slide. And all of the important immunodeficiencies that you might be tested on fit into one of these 6 categories, where the T cells, B cells, and neutrophils are either absent or they're present but dysfunctional. So the absence of T cells, which we'll discuss further, is severe combined immunodeficiency. An example of a situation where T cells are present but broken is Wiskott-Aldrich syndrome. The absence of B cells is X-linked agammaglobulinemia. And the canonical definition of common variable immunodeficiency is a lack of humoral function, even though the B cells are present. The absence of neutrophils is severe congenital neutropenia. And an important example of dysfunctional neutrophils is chronic granulomatous disease. That's it. Just remember those 6 boxes and you'll be okay. So now we're going to go through these in order, starting with SCID. SCID is called combined because, as I've tried to drive into you, if you lack T cells, you automatically lack B cell function. So the absence of functional autologous T cells is uniform. The B cells can be present or absent, but even if the B cells are there, they don't usually function. In other words, there's no specific antibody production. And as you know, in the most typical form with an absence of T cells, this is a disorder that is generally fatal before the age of 2 due to overwhelming infection. So the diagnosis of SCID in the United States has changed. It was historically diagnosed by symptoms, and all those symptoms listed on the left are the kinds of things that would come up in boards questions. However, it is currently now diagnosed in the United States at birth due to this evolution of a test for T-cell receptor excision circles, or TREX, in dried blood spots in the newborn nursery. And TREX were added to the recommended uniform screening panel in 2010. So what are TREX? At the peril of causing you to have flashbacks to medical school in VDJ recombination, I'm going to explain it here. As I told you before, the T cell receptor beta and T cell receptor alpha loci rearrange serially in the thymus. So the TCR beta at the double negative stage and the TCR alpha at the double positive stage. And it is at this stage that the TREC that is being measured in the newborn nursery is generated. What happens is the TCR delta locus is embedded between the V alpha and the J alpha of the TCR alpha locus. So when this is excised, when there's TCR alpha gene recombination, this generates a circle, an excision circle. And this circle is going to be the same in every single cell, because even if V alpha whatever and J alpha whatever are connected, before that happens, which is a unique rearrangement in each T cell, the whole delta locus is excised using the same sites. So the absence of TREX in dried blood spots indicates T cell lymphopenia, and the way we detect this is by doing PCR across this junction. So the basics for how to diagnose SCID is that you start always by checking the ALC, and you send lymphocyte subsets, and typically the T cells will be very low or absent. You send lymphocyte proliferation studies, and there should be absent or very low proliferation of T cells to mitogens. And then you can check total IgG, A and M, and specific antibody if the child has been vaccinated. Now, I'm going to go through a case in order to illustrate a couple subtleties. This is a real case of a 4-month-old boy who had chronic cough and failure to thrive, and he was diagnosed with pneumocystis pneumonia. This is a CBC. And now, in addition to calculating the ANC, which is 7,200, you also calculate the ALC, which is 4,200. And this falls into the normal range for age, 3,700 to 9,600. So the question is, could this child still have SCID with a normal ALC? So you go ahead and you send the T cell and B cell subsets. You see here CD3, 4, and 8 are all low, although you see that the CD8 count is not that low compared to the norm, that the B cells, if anything, are high, and that's driving the ALC to be in the normal range, and the NK cell count is low. So what does that mean? Well, it turns out that you can have SCID even with this number of T cells. And the reason is that you could have a situation known as maternal T cell engraftment. If you do a FISH on this child, then you will find that there are 2% of this male child that are cytogenetically XX. And this is because the degree of T cell dysfunction is so profound that the little bit of blood exchange between the mother and the baby in utero is enough for some of those maternal T cells to engraft, in other words, to proliferate and persist inside the baby. However, those T cells are not functional, and they are not very protective. And so therefore, if you check proliferation to mitogens, they will still be flat. And you can see that the baby is unable to make IgG because those B cells that are circulating are not able to respond to T cells. So the more refined version, because B cells can be present, a normal ALC does not rule out SCID. Because maternal engraftment can occur, the presence of T cells does not rule out SCID. You should send proliferation studies because maternal T cells do not proliferate, and the converse is true. Normal proliferation rules out classic SCID. You should check immunoglobulins, and the molecular defect can further be narrowed down based on the lymphocyte phenotype, although in reality, this is solved by also sending simultaneously genetic testing. So there are two major forms of SCID, those that preserve B cell development and those that abrogate B cell development. The ones that are T minus B positive are majorly comprised by these three defects, which all share in common that they are involved in cytokine receptor development or function. So the most common is defects in IL-2RG, also known as common cytokine common gamma chain, gamma C, or CD132. This is an X-linked disease and is the most common form of SCID in general. JAK3, or Janus kinase 3, is autosomal recessive, as is IL-7 receptor. And again, while these B cells are present, because they don't receive help, they do not produce antibody. Why are these diseases all related? Well, the common gamma chain, or gamma C, is the common component for all of these different cytokine receptors, IL-2, 4, 15, 21, 9, and 7. JAK3 signals downstream of gamma C, and that is why patients with JAK3, aside from the fact that they might be girls, have a very similar presentation to gamma C. Because IL-15 is required for NK cell development, and IL-7 receptor is what is required for T cell development. If you have defects in IL-7 receptor, but have intact gamma C, then you will lack T cells, but you will not lack NK cells. Moving on to B negative SCID, these are the three defects that are most common to cause T negative, B negative SCID. And whereas RAG1 or RAG2 and Artemis are involved in DNA rearrangement, adenosine deaminase is not. And this is what drives, as I will go through in the next couple slides, why RAG1, RAG2, and Artemis have an NK positive phenotype, whereas ADA deficiency causes NK negative phenotype. These are all autosomal recessive in inheritance. So RAG1, RAG2, and Artemis are all part of the machinery that allows T cells and B cells to rearrange the TCR receptor, the T cell receptor and B cell receptor loci. And this is why without these proteins, you have no T cell development and you have no B cell development. However, because NK cells do not have rearranged receptors, they are part of the innate immune system, as you recall from the first few slides, those NK cells develop intact. And this is why those patients have NK positive SCID. Whereas adenosine deaminase is an enzyme in the pathway of salvage for metabolizing nucleotides. Adenosine deaminase catalyzes deoxyadenosine to be changed into deoxyinosine. And when you lack ADA enzyme, you have accumulation of toxic metabolites such as DATP. This pathway is most active in lymphocytes, and the deficiency of ADA compromises all lymphocyte survival, T cells, B cells, and NK cells. So if you see on the boards a child who is lacking in all lymphocytes, then this is ADA deficiency until proven otherwise. What about the diagnosis and management of SCID? Supportive management is important: protection from infection, IgG replacement, aggressive diagnosis and prompt treatment of infection, and prophylaxis against pneumocystis. Remember that all blood products must be irradiated in order to prevent fatal transfusion-associated GVHD. In other words, that SCID child who is able to engraft maternal T cells, that tiny little bit of maternal T cells from their mom, is also incapable of fighting the little bit of T cells that might come along with a transfusion. Therefore, the transfusion must be irradiated. It's also important to realize that a patient with ADA SCID has a treatment option available before going on to transplant or gene therapy. In other words, enzyme replacement with pegylated adenosine deaminase enzyme. And then finally, the definitive treatment is immediate referral for hematopoietic stem cell transplantation. All right, these other disorders we're going to go through much more quickly than SCID because there's less that you're likely to be tested on the boards for these. So XLA, or X-linked agammaglobulinemia, is caused by mutations in the BTK or Bruton's tyrosine kinase gene. The reason why this occurs is that when you rearrange the immunoglobulin heavy chain and then complex it with the surrogate light chain to form the pre-B cell receptor, that pre-B cell must signal in order to go on to rearrange the light chain. And this is abrogated in the absence of BTK. So B cell development is arrested at the pre-B cell stage, leading to an absence of peripheral B cells. The T cells are intact and T cell immunity is normal. What happens then is you remember that the baby is born with IgG from the mother, and it's only after the maternal IgG has naturally declined that the patient starts to have infections, typically at age 6 or 9 months. And the treatment is IgG replacement. Moving on to functional T, B, or combined defects, defects in which the T and B cells are present but not fully functional or they're dysregulated. Wiskott-Aldrich syndrome, which I'm going to call WAS, is an X-linked disorder that is caused by mutations in the WAS gene. leading to a defective or absent WAS protein. This is a classic triad of immunodeficiency, eczema, and thrombocytopenia with small platelets. And remember, over and over, there are likely to be questions about Wiskott-Aldrich syndrome because the immunodeficiency people submit questions, the platelet people, and the lymphoma people. And remember, too, that there's basically nothing else that causes tiny platelets other than WAS. A complete lack of WAS protein usually leads to the full triad, but when young patients have thrombocytopenia and eczema, when patients are young, they may have thrombocytopenia and eczema with little immune defect, which worsens with time. Some patients may have missense mutations with detectable protein, which can lead to a milder form of the disorder, often called X-linked thrombocytopenia. These patients will typically have small numbers of small platelets that are low in number. They may have no or mild eczema, and early on they have normal immune function, but some of those patients, as they get older, may develop autoimmunity and closer to a WAS full-blown spectrum. Most of these boys will die by young adulthood from bleeding, infection, autoimmunity, or lymphoma. What are the laboratory features? This is a combined T and B cell immune deficiency. The T cell numbers are typically normal or might be slightly low. They may have functional defects. The B cell numbers are typically normal, but there is poor specific antibody production, and the classic finding is a lack of carbohydrate antigen responses. In other words, isohemagglutinins, anti-A or anti-B blood group antibodies, and poor responses to Pneumovax. IgG also does tend to decline over time. Another important feature of WAS is immune dysregulation. So again, there's eczema, there's typically allergy, they may have high IgE or eosinophilia. And then autoimmunity is very important. Autoimmune hemolytic anemia, ITP, on top of the already low platelets, vasculitis of the skin, arthritis, and colitis. The diagnosis is made currently by measuring WAS protein levels by flow cytometry and gene sequencing. Splenectomy can correct thrombocytopenia for years, and the late manifestations include a lot of the autoimmune type complications and also a failure of cancer surveillance, in other words, the development of lymphoma. And supportive therapy includes Ig replacement, platelet transfusions if needed, management of the complications and treatment of infection. However, there are excellent outcomes when transplant is performed in childhood, less than 5 years old, with well-matched or unrelated or unrelated donors. It is notable that a high level of donor chimerism is needed in order to correct all features, particularly the platelet count. Moving on to X-linked lymphoproliferative disease, or XLP. This is an X-linked disorder due to mutations in the SAP gene. The SLAM-associated protein is encoded by this gene SH2D1A. This is an adapter protein that associates with the SLAM family of receptors on multiple lymphocytes and other cells. The thing about XLP that is notable for taking the boards is that there are many different types of presentations, and some of these clinical scenarios are very classic and really prime for boards questions. First, there is the historically very important fulminant and often fatal acute mononucleosis syndrome in XLP due to EBV, which typically has a very poor outcome. They may have lymphoproliferation, which is typically non-clonal, or they may present with recurrent infections with either hypogammaglobulinemia or sometimes normal total amounts of IgG, but dysgammaglobulinemia, in other words, very poor specific antibody and a lot of antibody against one antigen running around. They typically have a pretty bland laboratory evaluation, and transplant is being increasingly used for this disease. Common variable immunodeficiency, or CVID. This is a heterogeneous group of disorders, and while most of the molecular defects are not known, we are definitely discovering more and more genetic defects that are associated with a CVID phenotype. The typical onset is in adults, so this is generally not a pediatric disease, onset 20 to 40 years. The clinical definition is that this is a disorder of humoral immunodeficiency. In other words, in order to have a diagnosis of CVID, there need to be decreased levels of IgG, IgA, and or IgM with poor or absent antibody production while excluding other genetic causes. Unlike XLA, the B cells are detectable, and the patients often have defects in T cell number of function. These are, again, not required for the definition, but what seems to separate the more severe CVID patients from the less severe CVID patients is this matter of whether the T cells are lower in number or somehow dysfunctional. Those patients tend to then have additional complications that can't necessarily be solved by IgG replacement, such as autoimmunity or granulomatous infiltration or lymphoma. And as I mentioned, there are molecular defects that are being increasingly discovered. Like other antibody deficiencies, they're prone to sinopulmonary infections, chronic enteroviral meningoencephalitis as well. And particularly important for the hematologist, autoimmune disease, especially autoimmune cytopenias, are quite common. And then the treatment is IgG replacement and supportive treatment of infectious and autoimmune complications with a limited but expanding role for hematopoietic stem cell transplantation. Finally, ALPS, autoimmune lymphoproliferative syndrome, which is also partially covered by one of the other lectures. This is a lymphoproliferative disease that is caused by defects in pathways controlling apoptosis of lymphocytes. The molecular defects are being increasingly understood. Some of them are listed there, with the germline heterozygous or somatic heterozygous defects in FAST being the most common. And again, the reason why the hematologist is likely to encounter this disease is that autoimmune cytopenia is often a presenting symptom and is very common. The diagnostic criteria are listed on the side there. The treatment, much of the therapy is directed towards management of cytopenias. This may include steroids, MMF, 6-MP, rituximab, sirolimus, and others. There is a role for splenectomy, but exactly when it should be done and whether it should be done is controversial because of the risk of sepsis. And the penetrance is highly variable. Survival to adulthood with FAST mutation is quite good. And later manifestations such as lymphoma can be very challenging to treat. Finally, I'm just going to wrap up with the approach to transplant for immunodeficiency, because I suspect that questions like these are beginning to come up on the boards. So there are a number of disorders for which transplant is standard or commonly performed amongst the non-SCID disorders I'm going to talk about first. In the combined immunodeficiency category, this includes Wiskott-Aldrich syndrome, CD40 ligand deficiency, which I did not cover here, XLP, and then defects of neutrophil function, such as chronic granuloma disease and leukocyte adhesion deficiency. The principle here is to use a combination of agents for conditioning that have different purposes. You use busulfan-based conditioning for the most part, and that's because busulfan is the agent that will eliminate HSC and progenitors. You pair this with an agent such as cyclophosphamide or fludarabine, which are T cell targeting agents to prevent rejection. And it's this combination of stem cell kill and preventing rejection that makes up a myeloablative regimen, and that is the basis for a standard successful transplant. You should know that PK adjusted IV busulfan is now standard at most pediatric centers, and that agents such as ATG or Campath may also be used as further rejection and or GVHD prevention. SCID, on the other hand, and this is simplified for board's purposes, is a different biological situation. As I've told you, there's a profound lack of functional T cells, and this obviates the need for conditioning, particularly when you have a matched sibling donor. The other interesting thing is that HSCs and other progenitors can engraft directly into the thymus. Just as in the normal process of HSC leaving the bone marrow and engrafting the thymus, donor-derived HSC can also enter the thymus, take hold there, especially in the setting of SCID, where the T cell progenitors are often absent within the thymus, and then live there for decades and generate T cells. This is why you don't strictly need conditioning, because that process of the HSC going into the thymus and then generating T cells is not dependent on conditioning agents such as busulfan or killing stem cells in the marrow. Plus, the patient doesn't need agents to prevent rejection because the T cells are already absent. So for the purposes of the boards, there are many different types of donors that can be used. And I've put a little table here in terms of whether conditioning needs to be used, tends to be used and whether T cell depletion needs to be used. So for a matched sibling donor, you don't need to use conditioning and you don't want to or need to use T cell depletion. And this is because the matched T cells are very unlikely to cause graft versus host disease, particularly in the absence of conditioning, which tends to rev up the innate immune system and cause the T cells that are allogeneic to react. In the setting of a haploidentical parent, conditioning does not have to be used. There's a long experience of using haploidentical parent marrow or other stem cells. However, traditionally, historically, T cell depletion does need to be performed because those T cells are only half matched and would otherwise cause lethal graft versus host disease. On the other hand, in the unrelated donor setting, conditioning typically is used, and you may perform the transplant either with or without T cell depletion. Realistically, I don't think you're going to get questions about unrelated donor transplant, but I do think it's possible that you will get questions about haploidentical transplant. And definitely the answer for matched sibling donors is that you don't need to give conditioning. So that finishes up the content. And these are the references from which a lot of the content comes. And I am happy to answer questions. I've listed my new email down there below. And I'm also happy to take questions during the live question and answer period.
Thank you very much, Dr. Pai. We'll now open it up for the Q&A portion of the event. There was one question in the Q&A portion during the talk that requested a live answer, and I don't know if Dr. Pai could address that first.
Sure. So I just want to be clear, the questions that I've already answered in the Q&A are visible to everyone. Is that right?
I believe so, but it was suggested that if there were multiple questions on similar topics, we could probably try to hit some of those, or if there's time.
Okay, so one of the attendees did ask specifically about proliferation studies, and there was an earlier question about this, so I suppose I ought to address that. The question reads, can you explain what proliferation studies are during the live Q&A, and specifically about when to send them, or how one might feel more confident using those. So so to explain what they are, okay. There are a couple different ways to answer the question. I mean, for the purposes of the boards, I think all you need to know is that it's important to use proliferation studies to distinguish between a low number of T cells that are functional enough to probably protect the patient versus a low number of T cells that is to the point that the person is going to be at high risk of opportunistic infection. The more complicated or real life answer is that there are now two different ways that the proliferation studies are done. The traditional way is to take blood, isolate mononuclear cells, which includes lymphocytes and monocytes, and then culture them with these plant substances that don't work through the T cell receptor, are not antigen specific, and just cause the T cells to be stimulated and proliferate. And then in the last day of culture, after 4 or 5 days, you pulse with radioactive thymidine in order to see the incorporation of the radioactive nucleotide into the DNA, and then you count, how much radioactivity got incorporated into the cells. That's the traditional assay. Now, many laboratories have moved towards a different type of assay in which you take white blood cells. Usually, I think you also purify the mononuclear fraction, and then you expose them to a dye that gets taken up inside the cells, and then you stimulate the proliferation and watch as the dye dilutes because it's going to, as it'll be half the dye and then a quarter of the dye, etc. I think that, it's probably best on a real life basis to continue to consult with Immunology about these tests. I would say that the utility is subtle. It's in the setting of SCID, I think it's important to send them. For everything else, I think that, it's more of a subtlety. I hope that answers that question. There were
see.
several questions about maternal engraftment, and so I think I should address those. So a couple of different people asked whether maternal engraftment is going to affect the results of the TREC test. And it's in fact, in order to get around this problem of there being detectable T cells circulating, that the TREC test was developed in order to avoid maternally engrafted T cells being mistaken for like real T cells of the patient. The reason why maternally engrafted T cells will not lead to a normal TREC test is because first, TRECs are developed in each new T cell. So one cell, that gets developed will have one TREC inside it. But then as those T cells proliferate, the TRECs will not proliferate along with it, and so it will get diluted. So this means that adults who have a lower thymic output naturally and lower T cell count than babies will have low TRECs. Okay, so only newly born infants will have very, very high TRECs. And then the maternally engrafted T cells are coming from an adult, so they're going to have low TRECs. And the other reason is that those maternally engrafted T cells go into the baby and they get stimulated to proliferate because they're the only T cells there. And so those TRECs will get diluted even further. So maternally engrafted T cells will not score, as having a normal TREC. Somebody's asking whether a SCID with maternal T cell engraftment would affect the choice of conditioning regimens. This is kind of controversial, so I wouldn't say that this is something I can give a very definitive answer on. Certainly, if the patient has symptomatic maternal T cell engraftment, most transplanters, I think, in the field would say that it's worth trying to get rid of those T cells so they don't cause the baby more symptoms. There's a question about large granular lymphocyte leukemia and autoimmune presentations. To be honest with you, I don't think this is something that I'm capable of answering, so I'm just going to have to leave that there. Someone is asking, for what T cell count should you start prophylaxis for pneumocystis or fungal infection and avoid live vaccines? So this, I would say, is a little bit of a gray zone. I can answer it a few different ways. One is to kind of use HIV style numbers, so less than a CD4 count of less than 200 is probably, most people would agree that you should start prophylaxis. And then in terms of avoiding live vaccines, another way to put it is patients with DeGeorge syndrome, which I didn't cover here, but these are patients who can have poor enough T cell counts that they look just like a SCID on paper, and some people would call this a form of SCID. Those patients are that way because they have a developmental defect leading to a lack of thymus, a lack of the thymic organ. And some of those patients have very low T cell counts and some of them have decent T cell counts. My understanding is that those patients are also not supposed to be vaccinated with live vaccines, even if they have a pretty decent T cell count. So those are the two parameters I would use. Somebody's asking, can you discuss for boards, what are the indications to use ASPHO versus VORI versus fluconazole? Well, I mean, again, the difficulty here is that we do these courses based on pretty much what we ourselves kind of remember or have word on the street, about what the questions are going to be like. We go with the content specifications, but we don't know how quickly the questions change. So I would say that for this year's boards, I would probably stick with fluconazole being the standard for prophylaxis and echinocandin or VORI being the go-to for empiric coverage, assuming that the person was already on fluconazole for prophylaxis. I'm just going to peek quickly at the other answered questions to see if there were sort of themes. Somebody asked about why shouldn't there be a high risk of CMV reactivation in the first month because you've got low everything and you've got low lymphopenia. I answered that the risk is high then and that most people are on some type of prophylaxis. But the other thing that I forgot to say is that remember that monocytes are a very important reservoir for CMV. So there are two ways that you might have CMV develop during transplant. One is reactivation from the patient's own reservoir, and the other is transmission from the white blood cells contained within the graft. And for both of those, in that first month, the numbers are still quite low. So I think that's why in the end, even though you can have reactivation during that period, there's a higher risk at the time when those white blood cells have proliferated or are recovering after engraftment. Somebody asked about whether fever neutropenia management that I described would be the same in cyclic neutropenia. Remember that, FNN, when we're talking FNN in the context of high dose chemotherapy and prolonged neutropenia after transplant, this is also not just about the low counts, but about the exposure to and the loss of barrier function in the gut from mucositis. So I would not use what I described to be the answers for management of fever neutropenia in cyclic or other types of neutropenia without barrier compromise. Are there more questions that I'm missing?
No, nothing else coming in that I see anyway.
Yeah, I didn't dismiss those other ones.
I had a quick question just
yes.
because we have a little bit of time.
Sure.
How is immune reconstitution affected by some of the training sites for immune function? So if you had splenectomy going into a bone marrow transplant, or if you had thymic radiation resulting in thymic dysfunction?
Yes. Well, so certainly any radiation that hits the thymus is going to be lead to a further compromise in recovery of new T cell generation. All of the alkylating agents that people may have received for leukemia treatment are very damaging to thymic epithelium. So those things are both very important. And in general, the people who are being treated for non-malignant disease have a better time with T cell recovery. The other question was about splenectomy. I think the best example for how splenectomy can impact on immune reconstitution post-transplant is in the Wiskott-Aldrich syndrome situation. So WASP patients often have autoimmune cytopenias. And in the past, we used to treat them with splenectomy and then take them to transplant. And it's very effective in raising the platelet count. However, because WAS affects marginal zone B cell development, without the spleen, even after you reconstitute with donor-derived cells, they will still remain even more at risk of post-splenectomy pneumococcal sepsis because they never generated the appropriate responses before. 2 questions. Why conditioning should be used? And yes, well, so this is why, like that slide, like I had to do it because, over and over, I've been teaching this course for some time now. And afterwards, people would tell me, there was a question about transplant for skin on the boards. And oh crap, so that means I have to include it. So, the use of conditioning for unrelated donor transplant in SCIDs, if that's what your question is more historical. There is some experience with basically dumping in matched unrelated donor cells. The immunoconstitution isn't great. There's a lot of GVH. In terms of for everything else, conditioning needs to be used for non-SCID transplants because those patients are perfectly capable of rejecting a graft. The rejection of the graft is even more likely with an unrelated donor because of the allogeneic drive. So that's why you have to use it. And then combining post-transplant immunosuppression. I don't understand. Oh, you mean the thing with the 3 columns, the column A, column B, menu option. So the idea is that, well, let's put it this way. So it's very clear that you need to give something for graft versus host disease prevention in the allogeneic transplant setting. And the very oldest studies started with cyclosporin, when cyclosporin was even a thing. And then people found in Seattle, actually, from a randomized study, that when you added methotrexate, that cyclosporin versus cyclosporin plus methotrexate, cyclosporin plus methotrexate was better. And the idea is that you're hitting on 2 different mechanisms of how those allogeneic T cells that are going to spark the GVHD are proliferating. So first, you stop them when the T cell signals through the T cell receptor for making IL-2 and making other cytokines to get the rest of the immune system revved up. Second, the major action of IL-2 is to feed back on the IL-2 receptor of the T cell and make the T cell proliferate more. But if you are interfering with their proliferation, either by directly blocking the action of IL-2 receptor or by folate antagonism with methotrexate or with MMF, the way MMF works, which is also essentially in the nucleotide salvage pathway, then you are compromising the T cells from getting out of control. I hope that answers the question.
That's great. That is all the time we have. And I guess we're getting a phone call to tell us that. Thanks again for Dr. Pai for a great session. Thank you for attending the session. The chat and Q&A have now ended. The recording of the session will be available on this page later today. Also, please watch for further details regarding virtual office hours in late February or March for an additional opportunity to ask questions and interact with the speaker, Dr. Pai. The next session, neuroblastoma and related tumors, will begin at 2 p.m. Central Time. Please exit this room and join that session's room at the appropriate time. Enjoy the rest of your course, and thank you very much for attending.